Hi, I'm Dr. Vishal Vikas Nair, and today I'll be showing you how I do an endoscopic septoplasty. For infiltration, I'm using a pre-mixture of 2% lignocaine with 1:2 like adrenaline. Here I'm infiltrating on the contralateral side. One should always aspirate before injecting and look for blanching. Incision is always on the deviated side, and I leave a centimeter or so of the caudal strut to prevent any tip deformities. I then use the Freer's elevator to raise the perichondrial flaps and do not proceed till I reach the subperichondrial plane, which is a avascular plane. As you can see, we have reached the plane and the field is bloodless. One should never try to raise the flap beyond the deviation as this gives rise to a tear. I am now giving the cartilaginous incision. This incision is always behind the mucosal incision. This is to prevent any perforation. And now we have reached the contralateral side and are raising the opposite side flap. I am now creating an anterior septal window. Here I would like to express my gratitude to my teacher and mentor Dr. T.N. Janakiram sir, who has taught me this technique. And now we have space for the scope to go in and work. And now we are elevating the flaps on both the sides, reaching the bony cartilaginous junction. It is important to raise the flaps on both the sides and only then cut and remove cartilage or bone. As the perichondrium transitions towards the periosteum, elevation can become a little difficult. Here it is important to note that the pressure of the instrument should always be on the cartilage or the bone and never on the flaps directly. And as mentioned before, always raise flaps on both the sides and only then cut and remove bone or cartilage. And now we are elevating the periosteum. As you can see, in the right plane, it is completely avascular. The important point here is the pressure should always be on the bone or the cartilage and never directly on the flaps. Here's how we tackle the spur. We first make an inferior osteotomy. Ensure that the opposite side flap is completely free. We don't try and raise the periosteum or the flap over the sharp spur. Instead, we push the spur in the opposite direction. And once separated, we remove the bony spur and reassess. Part of the spur has been reduced as we can see here, but there is some bone which is still left. But as you can appreciate that the flap is intact. Now again using a Freer's elevator, we are pushing the bone to the opposite direction, dislodging it and then removing it. Now we further elevate the flap till the floor of the nasal cavity This is to prevent any tension in the flaps before we deal with the anterior deviation. Now let's see how we deal with the anterior deviation. So you can see there is a cartilage which is attached to the maxillary crest. Here I am trying to elevate the perichondrium of the contralateral side. And we use the Freer's elevator as a knife to separate the cartilage from the underlying maxillary crest. Now using Freer's with pressure at the right areas, we can remove bony deviations from the maxillary crest as well, as you can see here. As always, push the bony edges to the opposite side. Here we are taking care of the high DNS. On reassessing, we can see there is still some amount of anterior deviation on the opposite side. So let's see how we deal with it. Again, using a Freer's as a knife, I'm trying to separate it from the underlying maxillary crest. Using the Freer's almost like a chisel. And here we are removing the last bit of bone at the sphenoid rostrum. And finally, we reposition the flaps and reassess. As we can see that the spur has been completely removed. There is no tear. In spite of doing a great septoplasty, we can see that the patient also has bulky turbinates. In the next video, we'll see how we deal with them. Thank you for watching.